Good morning, everybody. Welcome to GIM Grand Rounds. As a reminder, this is a special Grand Rounds. This is the Grand Rounds we have in honor of Dr. Bob Britell. Dr. Britell, like our speaker today, was a child of the West. He grew up in Wyoming. He was a part of the D-Day invasion. He came back after World War II and married his wife, went to medical school, and after a sort of circuitous route through some rural practice in the West, ended up at the University of Colorado, recruited by our first chair of medicine, Dr. Gordon Micklejohn. He was a cornerstone of the department and one of the founders of the division. He actually was the founding chair of the Department of Family Medicine, which was launched as a part of the Department of Medicine and then became its own department when Dr. Britell recruited his replacement. Of all the hats he wore, the one that he was most proud of was his role as an educator. And so when Dr. Britell passed away, his family very generously endowed this lectureship, and we have the opportunity every year to invite a bright light in the world of education to come and talk to us about something new and exciting in medicine. So without further ado, I'm going to turn it over to Dr. Fust, who will introduce our speaker.
Good morning, everyone. Thanks for coming. Thank you, Mark. I'm really excited to introduce Dr. Ginny Sheffield here, who's going to be talking to us about approaches for equitable assessment. Dr. Sheffield did undergrad at UC Berkeley, then medical school, residency, and beyond at the University of Michigan, where she joins us from today. Interests include equitable educational spaces, mitigating bias in assessment, like we'll learn more about, supporting lactating trainees in the intersection of artificial intelligence and medical education. As we go, if you have questions, if you're attending in person, please raise your hand and I'll walk around with a microphone. And if you are attending virtually on Zoom, go ahead and type those questions in the chat and I can read them out loud. And with that, I'll turn the floor over to you.
Thank you so much. I'm really excited to be here. Closer to home than I normally am. I grew up in Los Alamos, and so I've spent a lot of time in Colorado. And in fact, more time than I would like to have spent at both the children and adult hospital here for unfun reasons. But it's nice to be here for a fun reason this time. I am Ginny. I am one of the associate program directors. And like they mentioned, I've been at Michigan for a while. It's a place that sucks you in, I think, a bit like Colorado is. And I'm going to be talking a little bit about how we can think about assessment and improve our practices to make sure that we're assessing everyone equitably. My first disclaimer is that I did use AI in this talk, mostly for some of the images I created. All of the content itself I generated on my own. I don't have any financial disclosures, but I do have some disclaimers about this talk, if I can get this to work. The first is that this work was not mine alone. It was developed by a group of people, and we, for the most part, are non-minoritized people. So very much what I will talk about today, I try my best to represent fairly, but I may get some things wrong, and I do want to improve. Similarly, the gender on bias often uses a gender binary model. We all know that that is not the true full spectrum of gender. However, the language I use will reflect the language that exists in the studies. Similarly, race-based data is often presented in a way that centers whiteness, and that itself can propagate some of the biases we have. And finally, while there's some studies that can identify the impact of intersectionality and bias, it's really hard to study. So a lot of this will focus on one identity, even though I know many people hold more than one marginalized identities at a time. I have these little symbols in my slides that I try to use when one of these biases or blind spots comes up. So if you see this, it represents that. So as any good medical education talk will, I'm going to try to engage the audience both out in Zoom world and here. I want you to take a second and, in one word or one phrase, tell me how you really feel when someone comes up to you, a med student, says, "Hey, can you write me a letter?" Or at the end of a rotation where you're exhausted and finishing up and you have that pile of assessments that you have to write for the students and residents that you worked with. You see drained, sagging, vague, unprepared. And I've given this talk probably at this point 100 times. No, probably not that many. But it always looks like this: responsible, anxious, vague. The one place that I had a bunch of positive words like honored and humbled was in the endocrinology division. So I guess if you want to like assessment, be an endocrinologist. Everywhere else, this is what I get. right? And that's okay, right? We are busy people. We are tired people. We weren't really trained in this, and it's a big responsibility on top of a million other big responsibilities we have. And so it's okay to feel all of these things, but we need to be mindful that when we feel this way, that's when our biases come out, right? So these feelings of being exhausted, of being rushed, that sets us up to potentially write unfair or biased assessments. So that's why I'm here today. The background is that we all know assessment is frequent in academic medicine. We have been doing it for however many years we've been in training and practice. It can be biased, and I'll show you the data on that today. But the most important takeaway that I want you all have today is that if we are intentional, thoughtful, and reflective, we can try to reduce this bias and improve the equity of the medical education spaces that we work in. So another quick poll, it should still be open in the last one, but have you yourself ever received an assessment that felt biased? And this is also very similar to most of the time I've given this talk, is that we know what this looks like. We know what this feels like, most of us. Some people are in a more privileged state where they actually haven't, and that's okay. And all of us can do better, right? Anyone who said yes here has probably also written one that was biased, because I know I have, despite the fact that this is something I spend a lot of time thinking about. So our path for today is I'm going to go through a little bit of background, give you some data on what the literature shows about how assessment can change, and then some strategies for what we can all do in our own educational spaces to improve this. So first, the background, why you should care. Why does assessment matter? I think for med students, we all know it's pretty obvious: grades, letters of rec, awards, the MSPE letter, our assessments go into that. For residents, similarly, advancement, jobs, fellowship match. We often forget, at least the students forget when I give this talk, that assessment does matter for us. It matters for promotion, right? One bad assessment can impact someone's ability to get promoted. It's used for awards. In my division, it's used to give a teaching bonus based on the assessment we get from learners. And all of that matters, but not as much as the fact that assessment impacts people, the way people see themselves, right? If someone is going through the world and every assessment they get is just slightly biased, they'll internalize that, and that will impact their outlook. It'll impact the way that they go through their career. So it is important. One piece of data to show us that the assessment matters, right? The MSPE is the letter that goes out to all residency programs when someone is applying, and it often uses quotes from our assessment. Now, I'm not going to lie, this is the lowest response rate I've ever seen published. They surveyed PDs, and I think they had an 8% response rate, but they got it published. So we got to take this data with a grain of salt. It looked at all different specialties. In internal medicine, they asked PDs how important they found the narrative comments in the MSPE, and 60% said they found it either very or extremely influential in their decisions. And then overall performance and clerkship was 96% found that very or extremely influential. So the thing we write after writing working with a student for 1 week can have an impact on where they end up in residency. And so if we know that assessment matters for these things, promotion, pay, awards, we're going to take a little brief detour to see how we're doing in that space, right? Are we doing well in kind of equitable representation? And I think you'll probably know the answer, but I'm going to give you some data anyway. This is a study it's actually getting old, it's 2016, but I really like the way they did it. They essentially compared the representation at each level in each specialty, from assistant to associate to full professor, and compared it to the general population of the US. They use this simple math that I'm sure we all remember, and it's easy to figure out. No, not easy. I once knew that, but I no longer know even what that means. But the most important thing for you to know is that an S score is generally representation of underrepresentation. So the higher the S score, the worse the representation is at a given level. And so they looked at all of these different demographic groups and saw how we're doing in academic medicine. At the level of assistant professor for internal medicine, so remember, a line going down means you're improving in representation. A line going up means you're getting worse. And you see that we had some gains for white women, but for every other demographic group, representation has actually gotten worse over time. If we go up to associate professor, we've made significant gains for white women, but again, every other demographic group has had worsening representation. And at the level of full professor, we haven't made much progress, and in some cases are getting worse. This is a more fun way to tell that same story. Has anyone seen this study? This is an actual figure from a journal, the BMJ. It's an article in the Christmas edition, and it was called Plenty of Mustaches, but Not Enough Women. For those wondering, I did not misspell mustaches. It's a British journal, so they had that extra, they always sneak extra letters in. But what they did is they looked at a cross-section of the top 50 NIH-funded medical schools, and they looked at the leaders in those schools. So the deans, assistant deans, all the leaders, and they compared how many were women, about 13%, and based on picture, how many had mustaches, about 19%. I see a mustache index slightly lower than that here. Actually, there's some mustaches in the room. And of course, this is tongue in cheek. And of course, one can both have a mustache and be a woman. But this story, right, this is interesting. And they did something, they calculated a mustache index, which is like the ratio of people with mustaches, women to people with mustaches. There were only 6 specialties that had a mustache index more than 1. And of course, this is 2015, but it probably hasn't changed that much since then. So that's a tongue-in-cheek way to tell the story. It's also been published in a non-tongue-in-cheek way. This is looking at leadership in academic medicine. The first study I showed you compared the general population to representation. This one compares the general population of a given specialty to the leaders in that specialty. So now we're comparing, so like if you say orthopedic surgery, they're comparing the rates of women in orthopedic surgery to the rate at the level of program director, chairperson. They looked, where do we have equity? And they looked at minority groups and women and assessed for change over time in addition to the single time point. Really important qualifier, minority in this study just meant non-Hispanic and not white. It didn't necessarily mean underrepresented in medicine or historically excluded groups. But what they found, I'll walk you through this table, which is obviously, just kidding, I remade the table so you could see what it showed. So a check mark and blue box means that you have parity in representation in the leadership position compared to the general working population in that specialty. And you'll see for us in internal medicine, there was no group that had parity in either race or gender. There's a few groups that have parity in program directors, but very few at the chairperson level, and none for women. They looked over time and they saw when comparing 2007 to 2019, right, we think we've made a lot of progress since 2007, things are getting better. Actually, only 2 specialties had an increase in the minority representation, and only 5 had an increase in female representation, right? So we aren't doing great, and we're not getting better as fast as probably we would like to think and hope to think. So how about pay? How are we doing in pay? This is 2021 data. There's new data out, but it wasn't framed in an easy way to present. So I'm going to share the 2021 data. This is the pay data from the AAMC. And on the left, you see men in clinical sciences. On the right, you see women, and you see there's not pay equity. And in fact, with a very rare exception, white men make more often than women, and women of all races and men of color, even after accounting for rank, specialty, and degree, right? That year, April 9th would have been Black Woman Physician Equal Pay Day, meaning a woman who is Black would have had to work through April 9th to make as much money as her white man colleague did the year prior, right? So it's not a small difference. This is more recent data. I just found this study yesterday. It's from 2026, and it's looking at the wage gap for Latina physicians. And in fact, it's not just a gap, it's a chasm. And so they looked at pay for Latina physicians and other groups. And this is what they saw. So this is the data when they pared it down just to people who work 40 to 60 hours a week, trying to account for that, part-time people are going to make less money. And you see on the right, how much less? 177,000 compared to 333,000 for a white man, right? That is huge. And in fact, over a 40-year career, that amounts to $4 million difference in the amount of money someone's making, right? That's not a gap, that's a chasm. So we're not doing great. There are inequities in medicine. I hope I've convinced you of that. But you're all thinking, but this is not what we came for. You said you were going to talk about bias in assessment. So could the thing I write at the end of working with a student for a week really be contributing to that pay chasm? It seems kind of far-fetched. But the argument I make and the argument that's been made in the literature is that yes, it matters because there's something called the amplification cascade. And that's the idea that really small differences in assessed performance over time down the line add up to really big differences in grades, selection for awards, and what we see here, promotion, pay, right? It's not some big overt person who someone said, we shall pay Latino women less. It's that all through their career, there's these small differences that add up to these big differences at the end of the day. And this figure kind of shows that you can imagine someone, perhaps she's going through her training, and in medical school, she gets slightly different assessments, which gets her into a slightly different residency, which gets her into a slightly different fellowship, and then faculty, and then leadership positions. And at the end of the day, right, it's a big difference in the outcomes. And that's what we see with those other studies. We could take this same premise and think about medical students as they're going through their rotations. Slight differences in internal medicine, surgery, pediatrics. And at the end of the day, there's really big differences. And we know this to be true because they've studied it. This is the Boatwright study of AOA membership. And they found that white students were 6 times more likely to get AOA compared to Black students and 2 times more likely compared to Asian students. And that's when they accounted for all those things that objectively we should be using to decide about AOA. Step 1, research, community service, gold humanism, leadership activity, right? Even after accounting for all those things, it was 6 times more likely for a white student to be nominated to AOA. And of course, assessments aren't the only thing that go into that, but they have to matter in some way. And if we have small differences all along, that's where we get these big gaps. All right, this is only over a 4-year period. So imagine as that compounds over a whole career. We can look at awards. This is a study from 2017 where they looked at a group of awards. There were 14 national awards across 7 specialties, and they looked at representation of women in each of those awards. This is a figure from the article, and it's a black dot represents a man, a white dot represents a woman as a winner of that award. And they found that 71% of the awards had never had a woman win it, these national awards. If I invert the colors on the graph, it's pretty stark what the representation looks like for these national awards. I also I'm a member of ACP, Michigan ACP, and so I decided I was just going to go on the Michigan AC or the National ACP website and count up the award winners of the National ACP Awards. Now, there's a huge grain of salt here is that I made a lot of assumptions based on names of people. I did not Google every person and confirm their gender. So this is not publishable data, but just me looking it up. And the first thing I noticed is that even of the awards, there are 22 of them, and 17 were named for men, and only 5 were named for women. So right there, that's a difference. When you look at the actual awards, over the last 90 years, 84% of the awards had gone to men. Over the last 10 years, 71%. And over the last 5 years, 68%. So we're making gains, but we're still not having parity. And this is in general medicine, right? Hospital medicine and general internal medicine, where we know we have fairly good representation in the working population. I looked at my own institution. Actually, when me and Paul worked together, we were co-chiefs, and I did this at that point. And we have this teaching award that's called the Marvin Pollard Award for Outstanding Teaching of Residents. It's the highest teaching award that a faculty can get from our residency program. What I found was that 91% of the time that award had gone to a man. And even in the 10 years prior to me looking at the data, it had gone to a man 82% of the time. I then took a look at the names. And in total, there were 55 awards. 5 went to women. At that same time, there were 3 Richards and 4 Roberts. So if your name was Richard or Robert, you were more likely to have won our highest teaching award than if you were a woman, right? Since then, we have redone the way that we do awards because we recognize the inequity, and we have much better representation of different groups. And so why does this matter? I think this cartoon, I think I saw it in 2020 in the midst of COVID. And to me, like, it's so powerful to think about this. Why does it matter who's getting awards? Because the people who are coming after them are looking up at the wall and saying, do I belong here? Could I be great? And if everyone who's getting an award looks the same, that's going to impact them. And of course, the picture makes you feel it, but we've also seen it studied. This is a study where they looked at the impact of just a picture on the wall. So they had folks go into a room and speak on a topic of their choosing, of their expertise, and then they rated themselves, and they had objective, someone else rating the quality of the speech. And the only thing that was different in the room, of course, we could make much better rooms at this point with AI. It's obviously a bit of an older study, but the only thing different in the room they were speaking was the picture of the person on the back, either a blank wall, a famous male leader, Bill Clinton, or a famous woman, Hillary Clinton or Angela Merkel. And that was the only difference in the room. And what they found was that women who had a portrait of a female leader spoke for longer, gave higher quality speeches, and rated themselves more positively. So they did better, and they saw themselves having done better. Right? That's powerful. Just having a picture of someone who looks like you impacts the way that you perform. And the good news is it didn't negatively impact the men. They weren't suffering because they had to look at a woman leader in the room, but it really helped the women. And so if we think about our academic centers, right, if this is a lecture hall, this is from an NPR article, this is a lecture hall in Harvard, someone taking a test in this room may do worse on the test because there's no one that looks like them held up on the wall as an exemplar. So this matters, right? It matters for how people perform. So of course, there's always a naysayer, probably not in this room, but like one of the first things people ask when you say, oh, all the awards are going, is like, maybe men are just doing better. Maybe they're just better doctors, or they're not at home as much. And so they're spending more time on their work. And that's why they're getting the awards. That's why they're getting paid more. The good news is we have data on this too. I'm sure many of you have seen this study looking at mortality rates. This is for hospitalists caring for elderly patients. And what they found was that when an elderly patient was hospitalized and a woman internist, they had lower readmission rates and lower mortality, right? It's also in primary care. This data is a little bit older, but women are more likely to have their patients complete mammogram and Pap screening, more likely to achieve target lipid, A1C, and blood pressure goals, and more likely to follow guideline-directed medical therapy for heart failure patients. In codes, this is the in-hospital cardiac arrest. They studied this, looked at 1,000 cardiac arrests, and about 30% of them had a female code leader. And patients who had a female code leader had a higher likelihood of getting ROSC and a higher likelihood of surviving to discharge. For surgeons, they looked at this, and this is a big study, 1 million patients, and those who were operated on by a woman were less likely to experience death, readmission, and major complications. And this held true at both the short-term follow-up at 3 months and the long-term follow-up at 12 months. So I'm not saying all of that to convince you that women are better doctors. I'm just saying that these inequities don't reflect the quality of care. And so, again, you're wondering, we still haven't gotten to assessment, and now you've just told me there's all these differences in awards, and none of those awards are based on assessment. But all of the differences that we see have had, in some small way or large way, been impacted by the way that person has been assessed, whether it's the way they present themselves because of something someone told them, or the opportunities they've had because of their grades. So now another poll. When you are sitting down to write a letter of rec or an end of rotation assessment, how often are you actually thinking about your own biases? I love the mix. My goal is that if I gave this same talk next week, I'd have 100% on the always, because it's critically important that we are examining our own biases when we are assessing others. So I've given you the background. Now I'm going to give you the data that's actually specific to the topic that I'm talking about today, differences in assessment. And studies have shown there's differences. So I'm going to give you a little bit of data on what this looks like in assessment. Oh, yeah, I love that, Jen. The IM evals have an explicit statement about bias. And then I wonder how many people read the explicit statement about bias before they complete their assessment, right? I've read it 1,000 times. I'm not going to read it this time, right? It's really important we have the same thing, but it's not going to impact everyone. But it has been proven to have a statement like that to improve the assessments that we write. So there's a lot of studies out there. Studies have looked in all directions of students evaluating faculty, faculty evaluating students, faculty evaluating each other, and residents. I'm just going to give you some of the key data. This is probably one of the most famous studies that looks at differences in language use. This is 87,000 third-year clerkship evaluations over a 10-year period. And what they found was that personal attributes like warm, lovely were much more likely to be applied to women, whereas the professional attributes like knowledgeable were more likely to be used to describe men. I really like the figure they created. So this figure shows on the y-axis is how much a word is associated with an honors grade. So the higher up it is, the more it was associated with getting honors. And on the x-axis to the right, you have words associated with women, and to the left, words associated with men. And you'll see all of these words about a personality, delightful, empathetic, compassionate, energetic, lovely, are much more likely to be used to describe women. They were powered to look at differences based on race, and they looked at underrepresented. I prefer the term historically excluded because it wasn't a passive process that they're not here. And they found all of these standout words, outstanding, best, exceptional, excellent, impressive, were more likely to be used for those students who are not underrepresented. Whereas the more nice, pleasant, good, less exemplary words, more likely to be used for the historically excluded students. They've looked at this in the MSPE, that study I showed with the 8% response rate, that this actually really matters to PDs, at least 8% of them. Again, women were more likely to be described as kind, caring, empathetic. White graduates, when compared to their Black, Hispanic, and Asian peers, were more likely to have standout words. And Black graduates were more likely to simply be described as competent. They actually did a subtextual analysis and looked at how the word competent was used. And when it was used for a Black student, it was more likely to be used in a doubt-raising way, whereas when it was used for a white student, it was more likely to be used as an actual compliment. And so, of course, especially when I gave this to pediatricians, they were like, but Ginny, what do I want my doctor to be if not kind, caring, and empathetic, right? Those aren't bad words that we're using. And that's not the point. It's not that we're using good words for one group and bad words for another group. It's that we're using a different set of words and a different language to describe different groups. And that harms both, right? Because I also want my men to be kind, caring, and empathetic. That's a strength. Why aren't we recognizing it in men as much as we are in women? And this study kind of looked at the impact of this on students, and there's a lot of good quotes in it, but this one, as a student from an underrepresented background, I feel my comments have largely focused on personal characteristics and not my clinical abilities. How do you prove to programs you're clinically competent if no one's commenting on that? What are they evaluating me on? She's a good communicator, she's eager. What does that say about me clinically? Sometimes it's very subtle. It's hard when students, especially underrepresented and meta students, don't feel seen. Not being seen is an endless spiral of poor evaluations. Right? It's not that we're saying bad things. It's that we're just commenting on their personality. And if we're just commenting on someone's personality, what are we leaving out? What competency are we not highlighting? They looked at this in surgical residents as well. Women were more likely described with modulating phrases. She has the potential to succeed, while men had more positive comments overall and were simply expected to succeed. Right? It's a really subtle difference. It's kind of raising the doubt a little bit, like she has the potential to do it, but I'm not sure she's gonna, versus he will be a leader, right? And they were more likely to see and describe the men as leaders. And why is that? Because when you look at the rooms, there's a lot more mustaches than women. So of course we're gonna project, oh, a leader is a man. This is my own institution, in full disclosure. Me and Dr. Chris Stein were medical students at the time of this, so we are part of the problem in this situation. But they looked at student evaluations of faculty now, 140,000 teaching evaluations across all the core clerkships. And what they found was that female faculty were rated lower in all domains. And there was no difference based on the medical student gender. So it doesn't matter if you have gender concordance or not, the women were getting lower evaluations. This is a study that looked at gender of faculty and how they were described by the residents or by trainees. And they analyzed 7,000 plus student evaluations for 500 faculty. And again, there were differences in the words that students used to describe the faculty, right? Women faculty were more likely to be described as warm, delight, empathetic, and men were more likely to have the term master, humor, art, right? It's not a simple thing as good and bad. It's just different. Why are we commenting on humor for a man and empathy for a woman? This is a study that we did in our program looking at the resident evaluations of faculty now. And what we found, we didn't do a textual analysis, but we looked at the milestone ratings. And we found that men were rated higher in overall teaching and 4 of the 6 ACGME domains. And while we didn't look at the text, the patterns there, right? It's the interpersonal communication and the patient care where there wasn't a difference, right? Those are the warm, caring, empathetic terms that sometimes maybe we associate with women. And this difference was actually much, much larger on the inpatient setting compared to the outpatient setting. And in the inpatient setting, men were rated higher across the board. And we posited that this had something to do with the different expectations of communal traits in the clinic setting compared to more agentic traits in the inpatient setting. And for the researchers out there, I do want to highlight that y-axis. You're like, come on, Ginny. 4.63 versus 4.69, and you're going to try to tell me that's significant? Sure, you found some positive statistics, but right, what is the impact of that? And I would tend to agree with you in many situations, but in this situation, remember the amplification cascade. And if I tell you that in the Division of Hospital Medicine at the University of Michigan, the way they award teaching evaluations is they take everyone's numbers, line them up, and the top 20 get an award and some money, right? It doesn't matter if the difference between the top one and the 21st is 0.03, 3, or 300, right? What matters is there's a difference in the way people are being assessed. And we have to be cognizant of this differences when we're thinking about things like awards and pay. So in true Colorado fashion, I did include a mountain for you all to keep your attention. Here's us standing here. We're not in like a valley. We've started our trek. We've started our climb. The top of that peak there, that's a perfect world where we are assessing everyone equitably. And the path from where we are here to where we're going there in that perfect world of equitable assessment, it's not quite clear. There's some clouds in the way. I can't see the path exactly to get there. And that's kind of where the literature is. It's really easy to study and find the differences. It's less easy to study interventions and see if we're impacting those differences. But we're going to try. We're going to look at some strategies of what we can do in our clinical and education spaces to improve the assessments. And most of what I'll talk about now is drawn from this compilation of Macy articles. It was the 2023 Macy grants were targeted at this exact thing. And so a lot of what I'll share is strategies from these articles. If you have some extra time, there's some really nice articles in this compilation. And to be honest, I started giving this talk 5 years ago. And at that time, I started with, here's how you write. Here's what you write when you sit down to write at the end of a rotation with someone. Here's the words you use. Here's the words you avoid. And after reading those articles, I realized I was missing the biggest and most important part of equitable assessment. It's having equitable learning spaces, right? If we don't set people up for a successful and equitable learning space, they're not going to function their best. And so whatever we're assessing isn't the best version of them. So it won't be equitable. And so what do I mean by this, right? If we take a hypothetical student who we are rotating with, what we want them to be thinking about is medical knowledge, learning the facts, learning the treatment, learning the guidelines, and patience, thinking about how do I take care of patients at the bedside. But that's not what they're actually all thinking about. Some have a lot of other things on their plate. I'm sure I don't need to tell you what imposter syndrome is. This is persistent feelings of self-doubt. And it's more common for women. It's more common for minoritized groups. And it matters. This is a quote from a student. Imposter syndrome. Almost every student has it. The more minority group labeled you are, the more imposter syndrome you have. It's unfortunate, and it plays into how someone evaluates you, right? You feel like an imposter. You're not going to bring your full self to the table. I would be remiss if I didn't take a brief aside to say I hate the term imposter syndrome. Like, it's such a garbage term. I'm from Michigan. You may or may not know that it gets pretty cold in the winter in Michigan. Calling this imposter syndrome is like taking someone and putting them outside in Michigan in January in shorts and saying, hey, you have cold syndrome, right? This is a you problem, because it's not cold syndrome. You're cold because the environment is cold. People feel like imposters because they've come up through an environment that makes them feel like they don't belong and they're trying to fit in. So we need to reframe imposter syndrome and really think about how we create cultures where people don't feel like imposters and not blame them for feeling like imposters. So instead of imposter syndrome, we'll just call it imposter phenomenon, which I think is a more reflective term. What can you do about it? Acknowledge it, right? Say it. Let people know when you're feeling it. I mean, I'm not going to lie. I feel like an imposter being flown to Colorado to give some talks, right? But if we all acknowledge that we feel it, then people will say, hey, they'll come to you and say, I'm feeling a little bit of self-doubt, and you can talk them through it and help them through it. And hopefully they'll be able to work better because of that. There's also something called stereotype threat. This is the idea that an individual will be worried about performing up to a negative stereotype and thus will perform worse. This is the idea that if you take a group of second graders and you tell them, boys are better at math than girls, and then you give them a math test, the girls will do worse on that math test than if you had never told them that, right? This is the fear of living up to a negative stereotype. And for students who are minoritized in medicine, they're walking around with this every day, worrying that they're going to confirm the most negative stereotype of whatever their identity is. This is another quote from a real student. If I notice that I'm one of the few people of my race or ethnicity, I start to feel self-conscious about myself and how I present to others, right? You're not going to put your best foot forward if you're feeling continually self-conscious. So again, how can we help with this, right? Talk about it. Recognize that everyone falters. Be really clear when you get something wrong. Hey, I said XYZ yesterday in clinic, and then I looked it up and I was totally wrong. I expect that we will all be wrong sometimes, and that's how we grow, right? Normalizing self-doubt, normalizing that it's okay to be wrong, and you expect everyone to. You don't have different expectations for different people. There's also the obvious micro and in many cases, frankly, macroaggressions from all sides, from patients, from colleagues. And we know that women and minoritized physicians are more frequent targets of these behaviors. This quote, oops, we've lost it. This quote is coming from a Black student who walked out of a room where he was called a racial slur. I didn't say anything, and I wish I had. But like at the time, I was like, oh no, your career is on the line. Imagine you are in a patient room and they call you a racial slur, and you walk out, and your first thought is, what about my grade? What if I respond the wrong way? Right? And then you're walking down the hall and giving a presentation to a faculty. How are you possibly going to do that well when you have all of that in the back of your head? Right? Some people have a lot more weight that they're carrying in every space they're in. But we can do something about it, right? When you're working with new people, whether it's for a day or for a week or for a month, prepare them in advance. Say, hey, I know people say inappropriate things. It's not fair, and I'm not okay with it. I'm a safe person to come to. If you're there when it happens, address it in real time, respond. After it happens, debrief, check in, make sure they're okay, give them space to recover and heal. And this is another project that we've done. I did this with a colleague, Luke Fraley. We have a workshop we give, and this is a badge backer that comes with the workshop. So you'll walk around the University of Michigan Hospital and you'll see most medical students and all internal medicine residents have this badge backer. And it has key phrases that can be used in these situations to empower people. And we find that I get caught flat-footed when someone says something ridiculous or rude, and having these phrases with me helps me to respond in real time. As a student, I didn't respond, but as a faculty, I see it as an obligation to stand up and respond for the trainees when I see this happen. The final piece that impacts the learning environment for some people is the hidden curriculum. This is the idea that students who are the first in their family to go to college, let alone medical school, aren't going to have the insider knowledge that it takes to really succeed. If my sister just graduated med school last year, she's going to explain to me exactly how to look good on rounds, right? Oh, you bring an article and say this. Oh, here's how you scrub in without making anyone mad. But some people don't have that benefit. But that's really easy for us to fix. We just give really, really clear instructions on what we expect. On day one, print it out, explain, here's what an honors level presentation looks like for me. Here's what I want you to be doing day to day. Here's what time I think is appropriate for you to get in. So don't leave them questioning how are they going to succeed? What's the best way to go forward? So making expectations clear. And of course, we come back to our student. What we want them thinking about is the books and the patients. But for some of them, there's a lot of other things on their mind: imposter syndrome, stereotype threat, microaggressions, and the hidden curriculum. But we can't make these things go away, right? We can't change the world, but hopefully by making small changes in the way we set up the learning environments, we can make them melt to the background, and then the other things that we want them to be thinking about can come to the forefront. So it starts with creating an equitable learning environment. And then when we get to the end of a rotation or the end of a day or the end of a clinic with someone, we do have to work on our own skills of thinking about, how do I assess someone fairly? Which do I use? What language do I avoid? And again, we put together a one-pager that I'm happy to share with anyone who feels helpful, that goes through some of the background and some of the steps. But we have kind of 5 steps that we think are helpful when you're thinking about assessment. The first step is examining your own bias, right? I'm sure many of you have heard of the IAT, the implicit association test. I was raised by a nuclear physicist for a mom, and I still have an implicit association that men are scientists and women aren't, right? My entire life, the closest woman to me was a nuclear physicist, and I still have this bias. So just being mindful of our biases is helpful. Reviewing the literature, I tried to do that a little bit for you here today. The second step is taking notes, right? Someone in the Slido at the very beginning, their one word was, did I take notes, right? Because if you don't take notes, you don't remember. And when you don't remember, you kind of just write vague things. And when we're writing vague things, our more deeply ingrained biases are more likely to come out. So really take notes when you see something. It doesn't have to be full sentences. I always just have a notes app open. I'm like, oh, remember they brought this piece of data to rounds today, and it was really good. Take your time, which I know is a little bit of a joke because I know quite literally none of you have any time to take. And as best you can, really don't rush through these and don't wait too long, because both rushing and waiting will result in less detailed and thoughtful descriptions. When you are writing, you want to be really specific. Use observations, not inferences. Be specific with observed behaviors and think about the competency, not the personality. Review your work after you've written it before you hit submit. If I were learning, would this help me grow? Is my assessment impacted by the identity of the learner? And then here's a list of words to think about, including if you're trying to write a very competency-focused assessment, and words to think about avoiding if you're trying to avoid some of those personality descriptions. And this, I'm sure many of you have seen the letters of rec handout from the University of Arizona. The idea with these words was adapted from that. So vague descriptions of what to do aren't always as helpful as really specific examples. So we'll go through a few. She was friendly and compassionate. Great. Those are really good things to be. But they're personality traits. They're not competencies. So think to yourself, why was that a good thing for her to be? Well, because she was skilled at quickly gaining trust and establishing therapeutic connections with her patients, right? In this way, we're changing it from a personality to a competency, right? Interpersonal communication is a core competency that we're expecting of all of our graduates, our residents, and our students. But even more importantly, right, that self-reflection piece. If someone goes through the world and everyone tells them, you're nice, you're nice, you're nice, right? They don't think of it as something they've actively done, right? But it's actually not a passive thing to maintain being nice, right? That is a skill that you have honed over your lifetime of figuring out how to make other people comfortable, how to set yourself up for success in a conversation, how to establish trust. So it's not just the personality that makes it better. It's because it's a skill that doctors need. He was not interested on rounds. Okay, that's kind of your assumption. I doubt he raised his hand and said, excuse me, Dr. Sheffield, I'm not interested, right? So what did you see that made you think he wasn't interested on rounds? He frequently looked at his phone and did not speak. Now I'm seeing the observable behavior and not what you think it meant. So one key piece here is check in with the student or resident before you write this. See if there's something else going on. Maybe they have a loved one in the hospital and they're getting text messages with updates. Maybe they use their phone as a hearing device, and so they're actually reading closed captioning of what you're saying. There are many reasons, but if you check in with them and there's no other reasons, then describe it. And again, it's not only because it's an inference, but now this student reads their assessment and thinks, oh, that's what I did wrong. Now I know next time I should put my phone away and respond to questions, and that's how I'll show I'm interested. So you actually are giving them something specific to work on. She was quiet, but participated well. Quiet here is a bit of a doubt raiser, right? Like, why do you need to say she was quiet if she participated well? She listened well. Like, being quiet is also a sign that someone's listening, which is a good quality in a doctor, and participated thoughtfully. Right? You don't need to comment on when she was quiet if she participated. If she was so quiet, you have no idea how to assess her knowledge. That's a different thing, and you can think about how to reframe that. I think this is our last poll, but I'm going to ask this question. Has anyone ever told you that you need to be more confident, either in written or verbal feedback? If anyone in the room has had this, how did it make you feel? Did it make you feel more confident? Right? This is a really common thing that we tell people. Who has told someone to be more confident? Right? I have. And it seems like this is probably a helpful thing to say. But in fact, certain groups are told this much more often. Women are told to be more confident very frequently. Guess what happens when a woman is confident? She's told that she's too assertive, that she's rude, that she's not, that she's just a little overconfident. So it's this very thin line that people have to try to skate, right? And actually, this is another thing that has been studied. So at baseline, right, imposter syndrome, stereotype threat, make women come to the table already with lower confidence and lower perceived skill, even when their skills are equal. Right? If you give a woman a test and if you give two people a test, the woman will guess that she will do worse than she does. And then in some cases do better than her society has raised us. It's no one's fault. But women are already coming in with lower confidence, even if they're doing incredibly well. And then this study found that they were much more likely to be told to be more confident. And it was often associated with being underconfident. And then being told to be more confident was associated with lower competence scores from faculty. So let that sink in. When we tell someone to be more confident, we then go and assess them as less competent, right? Those two things, while they shouldn't be linked, they are. And so if we're telling someone to be more confident, we are actually then perceiving them differently and rating them differently. And on top of that, when you tell someone to be more confident, it has the actual negative impact of making them less confident and questioning themselves more, right? So when we're thinking about how we rephrase this, right? She needs to be more confident. Why? Is it because she was in a room with a patient and they didn't trust her? Well, that's a problem, right? Then you say, hey, I noticed you said, I noticed that you kind of asked questions instead of getting assertive answers. And I saw that the impact was the patient you lost them and they started looking at me. Let's think of ways that you can speak with patients that keeps them focused on you, right? It doesn't have to be about confidence. It has to be about what looked like underconfidence and how did that impact the patient? If it's just, well, she's whip smart. Why doesn't she know she's smart? Telling her to be more confident isn't going to make her recognize that. Focus on why you think she needs to be more confident. She has an excellent fundamental knowledge and humility, which allows for continued growth, right? We can reframe a lack of confidence as a breadth of humility. And humility is one of the most important things for a physician, right? Being able to admit, I don't know, I need to look it up. Being able to be humble with patients at the bedside. Humility, we in medicine have pathologized, but in my opinion, it's one of the most important things for a physician to be. And so when we're thinking about reframing this, the first thing we ask, is this just my bias that I want people to talk louder and be more assertive? Then that's a me problem I need to reframe, right? Is this impacted their ability to provide care or demonstrate knowledge? Well, then let's focus on that, the key observed behavior, not the quote unquote lack of confidence. I once gave this talk and someone raised their hand and said, I had to coach a medical student last week to be more confident because she was on the phone with a surgical consultant. And she kind of sounded like she wasn't sure what she was talking about. And then the surgeon yelled at her and asked to put me on the phone. So I wanted to coach her to be better. And my question was, why are we coaching the person who just got yelled at and not the person who was yelling at her, right? The problem isn't that a medical student isn't sure what to say, because she shouldn't be sure what to say. A medical student who's 100% sure of themselves is probably more dangerous than beneficial, right? So we really pathologize the person who's underconfident when really, I don't want my students to be that confident because they don't know anything yet. I don't feel confident half the time. So if I have a student who's confident, that makes me double check them a lot more. So the intervention shouldn't be on the person who gets yelled at for being underconfident. It should be at the person who doesn't have the patience to work with someone who's learning, right? So that's the talk. We went through some background on inequities in medicine, then tried to convince you that at least a piece of that through the amplification cascade has to do with bias in the assessments that we write. And then went through some strategies for change, which include not only the way we write assessments, but the way we set up the entire learning environment to be mindful. And it used to be that this was the end of my talk, but then things changed. And I had to ask the question, can the machine save us from ourselves? Will AI be the piece that solves the puzzle? And I'm going to talk a lot more tomorrow about AI in medical education, and I'll touch on this as well. And before I get into this, I just want to mention, I looked this up. University of Colorado does have a secure system where you can put student data and patient data that prioritizes privacy. So ChatGPT EDU, don't ever put student data into an open source thing because you are sharing someone's data that doesn't belong to you. So if you were ever going to think about improving your assessment or letters of rec with an AI tool, either have it de-identified or use a secure tool like ChatGPT EDU, which you'll have here. We don't have that at University of Michigan, so I don't know how good or bad it is. We have UMGPT because we have to brand everything that we do. Leaders and best. We need to think about when we are using these tools, GIGO, what does that stand for?
Garbage in, garbage out.
Garbage in, garbage out, right? So both the garbage that we write, right? If I'm asking a prompt in a way that's biased, I'll get bias out. But also we have to remember what these tools are built on, right? Well, first, no one actually knows because it's totally a black box. But also, there's a lot of frankly biased, racist, and sexist things in the data in the world on the internet. And those are all used to build these tools. So if we are not cautious, we have the potential not only to amplify our own biases, but to bring in biases from someone else. And so this is a study that looked at this. This is actually now maybe more than a year old, but this is one of those promptathons where people get together and kind of try to get a tool to do something. And actually with very little promptings, the AI tool, they could get to say, frankly, racist and sexist things, right? The first time you ask the question, it says, oh, I'm sorry, this is outside the bounds of XYZ. But if you ask it the questions the right way, it will spit out things that then confirm negative biases. So we have to be mindful of that. So if we take a hypothetical student, JJ, I want you to write an end of rotation assessment. She has a positive attitude, helped elevate the mood in the room, right? Obviously, garbage in, right? I just commented on her personality a bunch. I didn't mention a simple competence. And again, look at that really beautiful assessment. She has positive presence on the team, contributing to an encouraging and collaborative atmosphere, her positive attitude and supportive demeanor, right? Garbage in, garbage out just amplified the garbage I put in. And so if we stop here, we've actually not helped ourselves. But guess what? Oh, I highlighted all the things. She needs to be more competent. I can then ask, did this assessment contain any bias? And it's like, oh yeah, you really were biased. Think about quietness and confidence. That's a very gender term. Here's a way that you could say it differently. Think about the emotional tone. Positive attitude helped elevate the mood or strengths, but can unintentionally reinforce caring, supportive biases. And so here are some options for how you can do better. Would you like me to give you an updated version that focuses on competency? Right? AI has the ability to help us self-correct, but AI is also a sycophant. They're just going to give us what we ask. So you say, just write an assessment. Well, write an assessment that mirrors what I want. If you say, write an assessment that focuses on competency, right, now you can improve it. So we have to think about these as a tool that we use to collaborate with, not a replacement of our own thoughts. And so how we do this, you have to be really clear and specific. Frame your context. Who are you? What was the setting? Limit bias, right? Intentionally say, I want you to focus on competence. I don't want you to use any gendered or racialized language. And then analyze and adapt. And now I have an updated prompt that says focuses on the core competencies, system-based practice, professionalism, interpersonal communication. And you may ask, well, didn't that take you way longer to write than if you just written the assessment? Yeah, probably. But these parts I can keep from my own prompt bank and use it every time for every assessment and work on it. So it doesn't have to be. And the end of rotation assessment that I get back out now is much more objective, focused on competency and avoiding some of those gender terms. So now we're actually at the end. And I'll talk a lot more about AI tomorrow, but the take-home points from today are that assessment is frequent, bias exists. Even small differences through the amplification cascade can have large impacts, and through intentional reflection, we can minimize bias. How? Comment on competency, not personality. Focus on witness behaviors, not what you think they mean. Generative AI is a whole thing that we're still figuring out. And review what you write and what other people write and take it with a grain of salt. Last slide is just acknowledging some of the many people who contributed to this work that I'm thankful for.
I will lead us out with the first question. We have a few in the chat too. Thank you for this, first and foremost. Thank you for this, really informative. At a few different institutions, when it comes to assessments and grades, I've seen increase in practice towards the preceptor, the faculty, write the evaluation, and then there's a separate assessment group that often will de-identify in terms of removing names or removing pronouns of the learner. And I'm wondering, what's the data behind that to help reduce bias in assessment?
Yeah, so I guess I don't know the specific data. We do know the data about removing, right, a picture from an application or removing a name from an application that significantly impacts someone being hired. I don't know that removing the gender for the people to review, I don't know if there's any data for it, but I do wonder if it has the potential to amplify, because now I can't myself say, is this right? Oh, they commented on personality and all of these things. This is a woman, right? I don't know which way it would go, right? If I personally, when I'm reading letters of rec, I think about how could this have been impacted by bias? and kind of adjust based on that. I don't think most people do that. So it could be helpful, but just removing a pronoun doesn't remove all the bias that goes alongside the pronoun. But it removes the bias for the person reading the assessment. So maybe the second layer.
And then in the chat, question going back to the first third of the talk about background information. The question is that a lot of the data then seem to be from articles, manuscripts from academic environments.
Mm-hmm.
And so a two-part question. Do we know, is there data for non-academic environments, community about community practice about things like gender, race, ethnicity, and the impact of that on leadership roles there in the community? And do we know if people are leaving academics if they don't see themselves in leadership?
Yes. So part two of the question, yes, we know that people are leaving academics. We know that attrition in academic medicine is much higher for minoritized people and for women. And we don't always know the reason, but a big piece of that is right, that imposter syndrome, the environment that's not conducive to success, the constant self-doubt, the constant others doubting you. We do know definitively that people from these minoritized groups do leave more frequently. The literature, I imagine there is literature out there about promotion. I don't know of it offhand. I think some of the studies actually looked at not just academic centers, but the pay gap, I think, is even wider in private practice than in academics.
Then our final question for this morning is about patient satisfaction surveys and star ratings. These seem, or someone in the chat has read, these are harsher on women physicians than men. Do you know any additional data on that?
So that I believe 100%. I have not seen that. Beyond that, just the expectations that patients have for primary care physicians is different. I'm sure you've all seen the literature on inbox messages, the number of inbox messages, the amount of time people are spending. So the expectations are different, and then they are judged differently. And so if we don't take that into account, that is another contributor to the bias and the burnout and the attrition.
We have one more question for Mark.
So terrific talk, Jenny. When I think back to when I first started as a faculty member long ago, I think it was accurate to say that the basis of a lot of evaluation was how did the faculty member personally feel. I mean, that's where it started, you know. And so so a student that you felt a really personal connection to, they tend to get, you know, better evaluations, and the faculty members sort of pulling for them. And you saw this phenomenon where, you know, there is this sort of sense that the students I work with are better than the other students. And I think we've done a lot over the years to try to make things criterion based and take that away. But my assumption is that's still at play. And I'm just curious, is there any data that looks at that, like sort of personal connection, attachment to, and how much the role of evaluator and sponsor get kind of blurred?
Yeah, so I, again, don't know the data specifically, but yes, that is very true. And I don't think it's that much less true today than it was whenever you train, right? It's just human nature that if we see people who are like us, come from places like us, have experiences like us, we are more likely to connect to them, thus like them, thus write a positive evaluation. And the impact of that is hugely important, because if we look at who has been excluded from medicine and medical education for the last several decades intentionally, right? If you just look at the Fletcher report, like we intentionally excluded entire groups of humans from being in academic medicine. They don't come from the same background that I came from. I grew up incredibly privileged in a mostly white town with nuclear physicists for parents, right? So I won't be able to see myself in them, and thus won't necessarily have that same connection. We have to actively counter that. And we have to create spaces where everyone can have mentors and sponsors. And part of that comes from intentionally not just promoting all the people who look one way, because when someone then has a leader who can be their sponsor and their mentor who's like them, that's good. But we also have to push ourselves to ask ourselves, is it just because this person's like me? That's why I'm so connected to them. And how do I broaden that reach of sponsorship?
Dr. Sheffield, again, thank you for this talk this morning. And I can speak for all of us. We're excited for you to expand tomorrow at noon in departmental grand rounds.
Yeah,
Thank
you
you
for the invitation.
Jeff.